there a clicker for the slides? Thank you. Thank you. So good afternoon, everybody. Thank you for attending this talk. I know it's hard after lunch. Hopefully everybody's digested. Today we're going to be talking about flipping the equation from traditional consumer insights to patient-generated data and the evolving role of telehealth in disease management. You know, it's a big sentence, and I'll tell you how we got here. It's an interesting story. Oops, did I just turn it off? Maybe not that interesting. Okay, so we had heard the conference was coming up. We thought it was interesting, given Sheval's background and kind of some of the portfolio companies that we've been working on. Both Sheval and I are entrepreneurs, and what we thought was, instead of having a specific topic before we decided to speak, we said, let's speak and figure out what we're going to talk about. And so what we did was we looked at each of the different companies that we work on and tried to diagnose what would be interesting to present at IIeX, given what each of these different companies do and how they could contribute some different perspectives. So obviously we heard all morning about consumerism and technology and how it's changing. So we looked at the technology company that we work with and looked at the different applications, and we thought maybe what we could do is pull data from these consumers that are using these applications and somehow come up with some interesting insight for all of you to share. You know, what we found was that these applications are being produced every day, by the minute, continuously, and you'll just see a swath of different types of applications that we looked at. We looked at paradigm. I mean, I can't tell you how many more and more bids and projects and requests that we get for different ailments, for physicians, for caregivers. It's exponential. And we continue to say, well, maybe there's something here that we can look at and kind of join forces and put a story together as it relates to the demand and what's going on in terms of the different issues in healthcare. But then we settled on looking at the industry and looking at exactly what's going on from a patient perspective. We've talked about technology changing patient care and how right now it's a very device-centric view of the patient, and nobody's really looking at patients in a holistic way. So we looked at C3 Nexus more closely, and here's my big data plug. We looked at it from the perspective of not just looking at technology and how it's improving patient care, but also thinking about it from a broader perspective and saying, can this data that's being generated for patients with this technology be aggregated and can be used in terms of other applications, in terms of pharmaceutical, for hospitals, and other types of areas. So with that, I am going to hand it over to Sheval, and he's going to talk a little bit more about C3.
Thank you, Sima. So I've heard a lot about doctors today, and so I think you'll get my perspective as a physician practicing cardiology in Richmond, Virginia. We've heard a lot about data today, and so the question that I have is, how do we convert data that can do two things? I mean, what do we want to do? We want to change behavior, because changing behavior changes outcomes on the consumer, on the patient side. And we want to aid our physicians to make better decisions at the point of care. So how can we use data to drive those kind of decisions to ultimately prevent and predict disease exacerbation? So if you think about the journey of a patient in their healthcare, 99% of that journey is outside the usual bricks and mortar ecosystem, hospital and clinics. And yet we spend all our time in the hospital and the clinic, but we ignore that universe of data, and that we're talking about the medical profession. What I hear today, what we heard in the previous talk, is that there is opportunity to tap into social. There is opportunity to tap into wearables. But where I've focused my energies on is really looking at medical wearables and how we can take that data and translate that into actionable insight to really change the outcomes that we're talking about. So, I always like to use a case study to really kind of center myself in terms of what we're gonna talk about, and it's really it's about patients, right? I mean, ultimately, we're all here because we want to help patients manage their disease. What we do a really good job of in the U.S. is managing acute care, heart attacks, strokes, trauma. What we don't do a very good job of is chronic disease management. So heart failure is a very common condition, particularly in the age group of a 70-year-old, and many of you may be involved in that aspect of care on the other side as caregivers. So this is an example of a lady that presented with high blood pressure, hypertension, atrial fibrillation, which is an irregular rhythm, and acute heart failure, which is, water in the lungs, can't breathe, short of breath, and it's a serious life-threatening type of illness. Now, mind you, and I'll touch on this later, that a lot of these symptoms are asymptomatic. These disease states are asymptomatic until they hit a critical point. High blood pressure, this heart rhythm irregularity. There are a constellation of factors that eventually come up to a perfect storm that leads to disease decompensation. But remember, it's not only about the disease. We have to have a more holistic view, and that's where we've got to look at other dimensions of the patient. Their weight, their health literacy, do they understand their disease, their socioeconomics, do they understand their medicines? So from here, we'll come back to her a little bit later. But really, think about this lady. She gets treated for in the hospital. It takes 3.5 days. She goes home, right? She's probably had 100 touches, and she gets a bundle of papers. Somebody's explained her meds, and now you're off on your own, and you go home and manage your health. So now she's at home. What does she do? These are the gaps in our healthcare ecosystem right now that really lead to what hospitals around the country are being penalized for, is that 30-day readmission. That's a $26 billion opportunity, and 3/4 of those readmissions are largely avoidable. So when the patient goes home, they're coming into the hospital sicker, and they're going home still quite sick. And yet, there's a poor handoff. They're still unstable. Medications, we talked a lot about medication adherence today. There's two aspects to it. There's medication reconciliation. So when they get home, all their meds have been changed. You're talking about the elderly who are already on 8 or 9 different medications. And they get home, and now they've got to figure out, what was I taking, what am I taking, and how does it all fit? And I can tell you from experience that half the time it isn't true. So that's an opportunity for error, right? So once you've got the meds straight, how do you know that they're going to take their medications? There are some great talks about medication adherence this morning. And it comes down to the 3 C's that Merck developed, right? It's cost, commitment, concern. Do I understand why I'm taking the meds? Am I concerned about side effects? And what's the cost, particularly of brand medications? Health literacy, education. Do I understand my disease process? Nobody talked about nutrition today, but that's a big part of it. Low sodium diet, heart healthy diet, and then fragmented care coordination, right? And access. So patients have multiple providers, and nobody's really coordinating that care. All right, so the traditional medicine view is episodic, right? It's wait till it breaks down and then go to the highest cost provider, which is me, as opposed to continuous care, using technology to monitor your vital signs remotely. Think about your heart. It beats 100,000 times a day, 35 million times a year. And yet we go to the doctor and we get a blood pressure and we get a heart rate. You go for your annual physical and the doctor says you're okay. But he has no visibility of what's happening 99.9% of the time. So it's episodic care. We've got to change that to continuous care. Incomplete data sets. Again, we're in a 15-minute office visit, we're limited to what we have about that patient. Can we think differently about how we deliver information that can enhance decision support on the provider side? Population management, treating to the mean. Guideline care is good, but again, we have the opportunity for personalized medicine between looking at data from physiology, from genetics, a variety of biomarkers. And then you look at medicine, right? It's been traditionally a patriarchal relationship between the doctor and the patient. And we've got to change that dynamic. We heard about the Uber model today and putting the consumer or the patient up front. I think what we have to start with is let's get to a partnership first and then realize that medicine is a team sport. It's not only the doctor may be the captain of the team, but it's nurses, nurse practitioners. There is a whole bunch of people that can manage the patient even better than I can with the conditions they have, and then escalate to me. So this is an interesting thing. You know, we hear a lot about personalized medicine and genetics, but genetics and genomics load the gun, but really what pulls the trigger is diet and lifestyle. So 8 behaviors and risks really drive 15 chronic diseases that account for 80% of our costs. So if we could change behavior, right? If we can change behavior with personalized data, get people to stop smoking, get them to eat better, get them to exercise, get them to take their medicines, those are the behaviors that can really prevent disease realization and also disease exacerbation. So one example of a chronic disease is heart failure. We talked about that. It's the #1 cause of readmission in the United States in the Medicare population. 6 million cases a year. You can see the data. It's really a disease of the elderly, but it's becoming a disease that we're seeing in other age groups too. So this is the low-hanging fruit that really I concentrated my efforts in my journey to figure out how can we help this patient population. So the perfect storm is really looking at, is happening in medicine. We don't have enough doctors. There's too many sick people. Patients are getting older. We don't have a good healthcare system. So the new paradigm is really looking at technology. The maturation of technology today has allowed us, between mobile, you know, your cell phone is your gateway to care, connectivity, wireless sensors, all that provides a lot of data to be able to change insight. So if you can take data from sensors, from whatever that source, and integrate that and feed it at the right time, at the right place, regardless of the disease state or the care continuum, you can change behavior. So it's really about liberating data from all these disparate sources and then being able to predict what's going to happen. So let's go back to our patient and imagine now that she went home with some technology that could monitor her heart rhythm, that could a Bluetooth-enabled scale, a blood pressure cuff, and a lockdown smartphone that could transmit this information to the cloud. Imagine she went home continuously monitoring her heart rate, her heart rhythm. And you had a platform now that could integrate all this data in real time and that could be alert-driven with workflows for decision support for a care team to look at this data. And you can see here that this was that lady that we saw early on. When she went home, within 24 hours, we got a heart rate alert that her heart rate's 150. We called her and she had no symptoms. I'm feeling fine. And so you can see that if that was not treated quickly, she would have been back in the ER within a couple of days. So remember, disease is silent a lot of times, and using technology to monitor and then to take action is critical. We did a pilot study in 140 patients with heart failure and heart attacks and reduced readmissions down to 4% all cause, which is dramatic. We recently got a grant, NIH grant, that's Mayo sponsored, to be done in Richmond, looking at the heart failure population and randomizing them to usual care versus the C3 platform. So in conclusion, I think it's important to embrace a data-driven participatory culture. Remember, the patient needs to have skin in the game, but we need data to really change behavior. Remote heart failure care is effective in risk avoidance and optimizing disease management. But it's not only about preventing that 30-day readmission, but it's about managing their disease over the long haul. Technology is not the end game, but it's an enabling tool, and it allows us to take patient-generated data and drive behavior change and, of course, enhance physician workflow. Because without a filter like a C3 platform that we've developed, all that data would come in unfiltered to me as the end user, as a cardiologist, and that would be totally rejected. So the idea is, can we convert that data using data curation platforms like we have built to enhance physician decision support, but also adoption. And of course, in aggregate, this data, we're treating one patient, one life at a time, but you can imagine now with a wealth of data over time, you can use this to provide other insights and predict behavior and disease. Thank you. Sima, if you want to come up. Any questions or comments?
Okay, well, I'll jump in. You mentioned when you were describing the woman by example that there were some other aspects that influence your ability to care for her ability to care for herself: obesity, fixed income, literacy. How do you integrate that kind of information into this overall assessment that allows you to get back to this person in the right context at the right time?
Great question. So I didn't emphasize that enough, but not only do we have a care platform, but we also have a care team with nurses, social workers, nutritionists. And so they're the team that interacts with the data and then interacts with the patient electronically or over the phone most of the time. So we're able to meet them where they are, understand them. So we talked about empathy today. That's what our nurses are trained to do, is really develop a relationship with these patients over time. And that's the longitudinal view that I don't have it with episodic care management, but they have a 24/7 longitudinal view to drive those changes and understand those dynamics in a holistic way. Great. Thank you so much.